Brain. Neoplasm. Brain neoplasm, acoustic neuroma, astrocytoma, brain metastasis. Craniopharyngioma. Ependymoma. Glioblastoma multiforme. Lipoma. Medulloblastoma. Meningioma. Oligodendroglioma. Pituitary adenoma. Acoustic neuroma. Description. An acoustic neuroma, also known as a vestibular schwannoma, is a benign fibrous tumor that arises from the Schwann cells covering the vestibule portion of the 8th cranial nerve. These tumors are well encapsulated, compressed but do not invade the nerve. Acoustic neuromas account for approximately 80% to 85% of all cerebellopontine angle (CPA) tumors and make up 10% of all intracranial tumors. Etiology. There is no known cause for this tumor. Bilateral 8th cranial nerve schwannomas are pathognomonic for neurofibromatosis type 2. Epidemiology. Acoustic neuromas account for approximately 5% to 10% of all intracranial tumors. They are the most common tumors affecting the cerebellopontine angle. Males and females are affected equally. The average age of onset is between 40 to 60 years. Signs and symptoms. Sensorineural hearing loss, tinnitus, and vertigo are common in patients. Imaging characteristics. Note: MRI is the imaging modality of choice. CT. Well-rounded hyperdense to isodense mass on non-contrast study. Hyperdense with contrast enhancement, MRI. T1 weighted, T1W, imaging without contrast is usually iso-intense to slightly hypo-intense. T1 weighted pulse sequence with contrast enhancement demonstrates the tumor with a marked enhancement. T2 weighted images may demonstrate an increase, hyperintense, in signal. Baseline imaging following surgery should include a pre-contrast T1 weighted and fat suppression post-contrast pulse sequences. Differential diagnosis include mainly meningioma, metastasis, and paraganglioma. Treatment. Surgery intervention is required. Prognosis. Depending on the size of the acoustic neuroma, the prognosis is encouraging and usually is curative. Figure 1. Acoustic neuroma. Non-contrast T1 weighted axial image demonstrating round iso-intense mass at the left cerebellopontine, CP, angle. Figure 2. Acoustic neuroma. Post-contrast T1 weighted axial image demonstrating an intense contrast enhancing extraxial mass at the left cerebellopontine angle close to the left internal auditory canal, IAC, consistent with an acoustic neuroma. Astrocytoma. Description: Grade 3, anaplastic astrocytoma. Astrocytomas are the most common primary intracranial neoplasm. They originate from the astrocysts of the brain. The WHO subdivided astrocytomas into 4 histology grades. Grade I, circumscribed astrocytoma. Grade 2, diffuse astrocytoma. Grade 3, anaplastic astrocytoma. Grade 4, glioblastoma multiforme. Etiology, epidemiology, unknown. Account for approximately 10% to 30% of cerebrogliomas in adults. Signs and symptoms typically are associated with an increase in pressure within the skull. May include headaches, visual problems, change in mental status, seizures, and vomiting. Imaging characteristics. Approximately 2/3 of all low-grade astrocytomas are located above the tentorium, supratentorial, mainly in the frontal, temporal, and parietal lobes of the cerebrum. CT helpful when MRI is contraindicated. Appear as poorly defined, homogeneous, hyperdense mass without fore contrast. Enhances with fore contrast, however, CIS does not enhance. Calcification seen in less than 10%. Edema and mass effect may be seen. MRI T1 weighted images appear hypointense. T2 weighted images appear hyperintense. T1 weighted with 4 contrast shows enhancement. Fluid attenuated inversion recovery, FLAIR, images show hyperintense tumor. Edema and mass effect may be seen. Treatment: surgery and radiation therapy. Prognosis: when detected early and removed completely, a good prognosis. 5-year survival rate greater than 90% is possible. Figure 1. Astrocytoma. Axial neck of the head shows a low attenuation mass in the left temporal lobe with surrounding edema. Figure 2. Astrocytoma. Axial keck shows mild enhancement of the mass which contains areas of necrosis. Figure 3. Astrocytoma. Sagittal T1W image shows an iso-intense mass in the left temporal lobe with surrounding low signal edema. Figure 3. Astrocytoma. Sagittal T1W image shows an iso-intense mass in the left temporal lobe with surrounding low signal edema. Figure 4. Astrocytoma. Post-contrast axial T1W image shows enhancement of the mass in the left temporal lobe. There is mass effect on the surrounding brain with effacement of the left ambient system. Figure 5. Astrocytoma. Axial T2W image shows the left temporal mass with surrounding high signal edema. Brain metastasis. Description: brain metastasis is the metastatic spread of cancer from a distant site or organ to the brain. Etiology: metastatic dissemination to the brain primarily occurs through hematogenous spread. Epidemiology: metastases to the brain accounts for approximately 15% to 25% of all intracranial tumors. Brain metastases may involve the supratentorial or infratentorial parenchyma, meninges, or calvarium. Most metastases to the brain parenchyma develop by hematogenous spread from primary lung, breast, gastrointestinal tract, kidney, and melanoma tumors. Metastases to the calvarium may result from breast and prostate cancers. Metastases to the meninges may result from bone or breast cancer. Signs and symptoms: depending on the extent of involvement, the patient may present with seizures, signs of intracranial pressure, and loss in sensory/motor function. Imaging characteristics: MRI is more sensitive than CT for the detection of brain metastases. MRI and CT show multiple discrete lesions with variable density along the gray-white matter interface. Show marked peripheral edema surrounding larger lesions. Post-contrast show ring-like enhancement on larger lesions. MRI lesions are hypointense to iso-intense to brain parenchyma on T1 weighted images. T2 weighted images show the lesions and surrounding edema as high signal intensity. Post-contrast T1 weighted images demonstrate the lesion as hyperintense and the edema as hypointense. Treatment: usually patients with multiple metastatic lesions to the brain are treated with radiation therapy, while patients with a single metastatic lesion may undergo surgical removal of the lesion followed by radiation therapy. Prognosis depends on the number and extent of metastatic lesions in the brain and if the patient has any evidence of other systematic cancer. Figure 1. Brain metastasis. Axial T2W image shows the left parietal mass with high central signal likely due to necrosis and high signal in the surrounding white matter due to vasogenic edema. Figure 2. Brain metastasis. Post-contrast T1W coronal MR shows multiple enhancing lesions with surrounding low signal edema involving the gray-white junction, white matter, and cerebellum. Craniopharyngioma. Description: craniopharyngiomas are benign epithelial tumors that are almost always located in the suprasellar region and occasional in the intrasellar region. Etiology: craniopharyngiomas arise from squamous epithelial rests along the infundibulum of the hypophysis or Rathke-Puck. Epidemiology: these tumors have a bimodal age distribution. More than half occur in children and young adults, while the second, smaller peak occurs in the 5th and 6th decade of life. Approximately 40% of craniopharyngiomas occur in children between ages of 8 and 12 years. Males and females are affected equally. Signs and symptoms. Patients may present with visual symptoms, obstructive hydrocephalus, and endocrine dysfunction. Imaging characteristics. Small tumors are typically well circumscribed, lobulated masses, while larger masses may be multicystic in appearance and invading the cellular. Craniopharyngiomas may present with calcifications, 90%, contrast enhance, 90%, and cystic, 85%, and measure between 2 and 6 cm in size, 75%. CT lobulated solid and cystic suprasellar mass. Calcification seen in approximately 90% of pediatric tumors, adults 30% to 40%. Contrast enhancement of solid portions and periphery, MRI. Appearance may be extremely variable, with most showing low signal on T1 weighted images and bright on T2 weighted images. Solid portions of the tumor usually enhance with contrast. Cystic areas may be hyperintense on T1 weighted images. Flare images appear with high signal. Treatment. Surgery is most commonly performed, however, the tumors may become so large that they are impossible to excise. Radiation therapy may also be used. Recurrence is common. Prognosis. Surgical resection followed by radiation supports a 10-year survival rate of 78%. Figure 1. Craniopharyngioma. Coronal T1W MR image shows a low signal suprasellar mass with small focal of increased signal which enhances with contrast. Post-contrast T1W coronal MR. Figure 2. Craniopharyngioma. Post-contrast T1W coronal MR. Figure 3. Craniopharyngioma. T2W axial image shows high signal within the cystic component of the mass. The punctate areas of low signal are due to calcification. Figure 4. Craniopharyngioma. Axial neck shows dense calcifications within a suprasellar mass consistent with a craniopharyngioma. Ependymoma. Description. An ependymoma in an intracranial glioma which arises from the ependymal cells which line the ventricle system and central canal of the spinal cord. Etiology, epidemiology, unknown. Most commonly seen in the fourth ventricle. This is the third most common pediatric tumor. Posterior fossa, infratentorial. Ependymomas make up approximately 10% to 15% of all pediatric tumors affecting the SNES and about 3% to 5% of all intracranial tumors in children 1 to 6 years of age. Signs and symptoms. Headaches, nausea, vomiting, ataxia, and vertigo. Imaging characteristics. Hydrocephalus is seen on most cases. Hyperdense enhancement with full contrast. Calcification, cysts, and edema may be seen on approximately 50% of cases. MRI appear hypointense to isointense on T1 weighted images. Appear hyperintense on T2 weighted images. Appears hyperintense with gadolinium. Treatment. Surgical intervention to remove as much of the tumor as possible. Conventional radiation therapy and stereotactic radiosurgery may also be helpful. Prognosis. 5-year survival is approximately 50%. Figure 1. Ependymoma. Axial neck shows a large mass with calcifications arising from the fourth ventricle and extending posteriorly. There is also hydrocephalus due to obstruction of CSF flow by the mass. Figure 2. Ependymoma. Sagittal T2W image shows the large irregular mass arising from the fourth ventricle, compressing the cerebellum and herniating down the spinal canal. There is also severe hydrocephalus due to obstruction of CSF flow. Figure 3. Ependymoma. Post-contrast T1W sagittal image shows irregular enhancement of the mass. Glioblastoma multiforme. Description. According to the WHO classification, a glioblastoma multiforme is also known as an astrocytoma grade 4 tumor. This rapid growing, Highly malignant tumor is predominantly located in the intercerebral hemispheres, though similar lesions may occur in the brainstem, cerebellum, or spinal cord. It spreads by direct extension and can cross from one cerebral hemisphere to the other through connecting white matter tracts such as the corpus callosum. Etiology, epidemiology, unknown. The glioblastoma multiforme is the most common primary intracranial tumor. It typically appears between 45 and 60 years of age. Males are slightly more affected than females. Signs and symptoms. Patients may present with nausea and vomiting, headaches, papilledema, change in mental status, seizures, and speech and sensory disturbances. Imaging characteristics. These tumors are located in the white matter of the cerebral hemisphere and will appear heterogeneous, with edema and mass effect. CT. Nodular rim enhancement with 4 contrast demonstrates a necrotic tissue center. Edema is generally present. MRI T1 weighted images present as mixed signal intensity. T2 weighted images demonstrate an increased signal, hyperintense, indicating a tumor and edema. T1 weighted contrast enhanced images will demonstrate nodular rim enhancement, the edema, and necrotic tissue as hypointense. Treatment. Surgical resection, if operable, radiation therapy, and chemotherapy are currently the methods for treating glioblastoma multiforme. Prognosis. Poor prognosis. The 1-year and 2-year survival rate is approximately 50% and 15% respectively. B. Figure 1. Glioblastoma multiforme. Pre, and post-contrast, B. Axial CT images show a large peripherally enhancing centrally necrotic mass in the right frontal lobe which is extending across the white matter tracts of the anterior corpus callosum. Note the surrounding edema and mass effect resulting in midline shift. B. C. Figure 2. Glioblastoma multiforme. Same patient as in Figure 1. T1W axial Mr. Shows an iso-intense mass with low signal central necrosis and surrounding edema. Post-contrast T1W image, B, shows peripheral irregular enhancement. Flare image, C, shows high signal edema. Lipoma. Description, etiology, epidemiology, unknown. A benign fatty tumor. Incidence of less than 1% of primary intracranial tumors. May appear at any age. Are usually located in the midline, 80% to 95%. Signs and symptoms. Asymptomatic, usually discovered as an incidental finding. Do not increase in size. Imaging characteristics, CT. Hyperdense appearance. Do not enhance with contrast. MRI. Hyperintense on T1 weighted images. Hypointense on T2 weighted images. Hyperintense on T2 weighted images indicate either fat or subacute blood. Fat suppression images will differentiate between fat and blood. Treatment. No treatment may be required. Prognosis. Unless the lipoma is positioned in a life-threatening location, the patient's prognosis is unaffected. Figure 1. Lipoma. Axial neck shows a small very low attenuation mass on in the midline consistent with a lipoma. B. Figure 2. Lipoma. T1W axial, and sagittal, B, images show small high signal intensity masses in both cerebellopontine angles. Medulloblastoma. Description. Medulloblastomas are rapid-growing, highly malignant tumors arising in the posterior medullary velum. Etiology. Arise from the embryonal cell rests in the germinative zone of the posterior medullary velum, a midline structure that contributes to the roof of the fourth ventricle. Epidemiology. These tumors are the most common posterior fossa neoplasm in pediatric patients and account for approximately 20% of all primary brain tumors in the pediatric population. There is bimodal incidence, showing a major peak in children between 5 and 8 years of age and a second smaller peak between 20 and 30 years of age. Seen more commonly in males than females at a ratio of 2 to 1. Signs and symptoms. Patients may experience hydrocephalus-like signs and symptoms such as increased intracranial pressure, ICP, ataxia, and nystagmus, and a herniation of the cerebellar tonsils can cause neck stiffness. Imaging characteristics. Non-contrast study is hyperdense, in the midline, displacing the fourth ventricle. Enhances with full contrast. MRI. T1 weighted images range from hypointense to iso-intense to gray matter. Hyperintense on T2 weighted images. Treatment. Methods of treatment may include surgery, resection, radiation therapy, and multi-agent chemotherapy. Prognosis. Good to poor prognosis depending on the patient's age, tumor location, and amount of tumor resected. Favorable prognosis factors include an age greater than 2 years, undisseminated local disease, and greater than 75% of the tumor resected. R. B. Figure 1. Medulloblastoma. Sagittal T1W image, R, shows a large low-signal fourth ventricular mass with multiple cystic areas. The solid component enhanced with gadolinium. B. Also note the hydrocephalus due to obstruction of CSF flow. Axial T2W image shows hyperintense cystic areas within the mass. Figure 2. Medulloblastoma. Axial T2W image shows hyperintense cystic areas within the mass. Meningioma. Description. Meningiomas are the most common benign intracranial neoplasms, and the second most common primary tumor affecting the central nervous system. Meningiomas are characteristically a hard, slow-growing, usually highly vascular tumor occurring mainly along the meningeal vessels and superior longitudinal sinus. They invade the dome and skull and lead to erosion and thinning of the skull. In some cases, these tumors may also grow on the spine. Etiology, epidemiology, arise from the meninges. Meningiomas are primarily adult tumors. They account for approximately 20% of all primary brain tumors. The peak incidence is between 40 and 60 years of age. Females are slightly more affected than males by a ratio of 3 to 2. The majority of meningiomas, 90%, are intracranial, and 90% of these are supratentorial. Signs and symptoms. The signs and symptoms a patient may present depends on the location and size of the tumor. However, headaches, seizure, nausea and vomiting, and changes in mental status may be seen. Imaging characteristics. Non-contrast study demonstrates a slightly hyperdense extraxial mass. Full contrast study demonstrates marked enhancement. Calcification is seen in 20% to 25% of cases. MRI. T1 weighted images demonstrate an iso-intense to slightly hypointense mass. T1 weighted images greatly enhance following gadolinium administration. T2 weighted images demonstrate a meningioma as iso-intense to slight hypointense. Treatment. Surgical resection is used to remove this benign mass. Radiotherapy may be useful when complete surgical removal is not possible or the meningioma recurs. Prognosis. Completely resected meningiomas provide an excellent prognosis with 10-year survival rate of 80% to 90%. Figure 1. Meningioma. Non-contrast CT shows round, high-density mass over the convexity of the right parietal lobe. Figure 2. Meningioma. Post-contrast CT image shows a round, markedly contrast-enhancing mass over the convexity of the right parietal lobe. R. B. B. C. D. Figure 3. Meningioma. T1 weighted axial MR image shows an iso-intense left parasagittal meningioma, R, and post-contrast T1 weighted images in the axial, B, coronal, C, and sagittal, D, planes. Oligodendroglioma. Description. Oligodendrogliomas are primary glial brain tumors. They tend to be slow-growing, solid, and calcified tumors. They are primarily found in the supratentorial white matter. Etiology, epidemiology, unknown. These tumors represent about 5% of all intracranial gliomas and 5% of all intracranial neoplasms. Males are affected 2 to 1 to females. These tumors may occur at any age, however, the average age when diagnosed is between 40 and 50 years. Signs and symptoms: seizures, headaches, change in behavior, weakness, or paralysis. Imaging characteristics: mass appear hyperdense with moderate swelling. Calcification is commonly seen. Edema is typically not seen. Enhancement with full contrast is variable. MRI appear hypointense on T1 weighted images. Appear hyperintense on T2 weighted and FLAIR images except in areas of calcifications. Low-grade oligodendroglioma typically does not enhance with full contrast, while an anaplastic oligodendroglioma does enhance. Treatment: surgery, radiation therapy, and chemotherapy. Prognosis: 5-year survival is 50%. Figure 1. Oligodendroglioma. Axial neck shows an ill-defined partially calcified mass with surrounding edema in the left frontal lobe white matter. Figure 2. Oligodendroglioma. Axial T1W image shows an ill-defined mass in the left frontal lobe that is iso-intense to the surrounding grey matter. Figure 3. Oligodendroglioma. Post-gadolinium T1W image shows minimal peripheral enhancement of the mass. Figure 4. Oligodendroglioma. Axial FLAIR shows a heterogeneous, hyperintense mass in the left frontal lobe which is fairly well circumscribed with some mild surrounding edema. Pituitary adenoma. Description: pituitary adenomas are also classified as either functioning or non-functioning, depending on their ability to secrete hormones. Etiology: the exact cause is unknown. However, there is a predisposition that pituitary tumors are inherited through an autosomal dominant trait. Epidemiology: pituitary adenomas constitute 10% of all intracranial neoplasms and are the most common primary neoplasm found in the sellar region. Occur in both male and females equally during the 3rd and 4th decades of life. Signs and symptoms: patients may present with frontal headaches, visual symptoms, increased intracranial pressure, personality changes, seizures, rhinorrhea, and pituitary apoplexy secondary to hemorrhagic infarction of the adenoma. Imaging characteristics: adenomas that measure less than 10 mm are defined as microadenomas, while those measuring greater than 10 mm are defined as macroadenomas. CT focal region of hyperdensity within the gland. Following contrast enhancement, the tumor will be isodense to the normal pituitary gland. MRI. T1 weighted images appear as a region of hypointensity within the gland. T1 weighted contrast enhanced images appear hyperintense. T2 weighted images appear with a variable signal that is unpredictable. Treatment methods may include transvenoidal pituitary resection, cryohypophysectomy, pituitary irradiation, or bromocriptine. Prognosis: the patient's prognosis is ranked from fair to good, depending on the extent the tumor spreads outside the sella turcica. Figure 1. Pituitary adenoma. Axial T1W MR shows a sellar mass that is iso-intense to the surrounding grey matter. R. B. Figure 2. Pituitary adenoma. Axial R, and coronal B, post-contrast T1W images show heterogeneous enhancement of the mass consistent with a pituitary macroadenoma.